Hello everyone and welcome back to our MRCP Part 2 High Yield Revision Series. I am Dr. Waladin and here we go now.
Hello and welcome to our topic about acute coronary syndrome, prepared by Dr. Waladin Ahmed via our YouTube channel MedPulse. This video is intended for educational purposes only and reflects clinical guidelines commonly used in Ireland, MRCP UK standards, and current medical practice at the time of creation. The content does not constitute medical advice and must not be used as a substitute for professional clinical judgment or consultation with a qualified healthcare professional. Clinical decisions should always be based on individual patient assessment, local policies, and the most up-to-date guidelines. All right, with the legalities covered, let's get straight to it. To the heart of the matter, you could say, and I promise that's the only time I'll make that pun.
We'll see.
Today, we are dissecting acute coronary syndrome, ACS. And I think for a lot of people, it just means heart attack, But looking at the sources we have with the 2020 NICE guidelines, the MRCP standards, it's so much more complicated than that.
It absolutely is. And that's a perfect place to start. Because treating everything as just one generic heart attack is, well, it's a recipe for a bad outcome.
Right.
ACS isn't one thing. It's a spectrum. It's really just an umbrella term for when blood flow to the heart muscle is suddenly blocked or reduced. So the goal for this deep dive is to get into the real decision trees doctors are using when a patient rolls in. We're moving past call for help and into what happens next.
Which brings us to, I guess, the very first challenge. Just identifying it. We all have that Hollywood heart attack image in our heads, right?
Yeah.
The person clutching their chest, pain down the left arm. How real is that?
I mean, it's real for a reason. That classic presentation, that crushing central chest pain, maybe radiating to the jaw or the arm, that's the textbook. And it's common. But relying only on that it's dangerous.
Yeah.
Because there's a huge however in the guidelines here.
The atypical presentations.
Exactly. And there are three groups of people where you are far less likely to see that classic picture.
Okay, so who are we talking about?
We're talking about the elderly, patients with diabetes, and female patients.
And in those groups, the symptoms are different.
Completely different sometimes. A patient with diabetes might have what's called neuropathy nerve damage, so they just don't feel the pain in the same way. The signals are blunted.
So what do they feel instead? What are the equivalents, as the notes call them?
Sudden shortness of breath is a huge one. Dyspnoea, or just, overwhelming nausea, vomiting, sweating. Sometimes it's just palpitations or a feeling of doom.
That's terrifying. So an elderly patient could come in, they look like they have a stomach flu, sweating, vomiting, but it's actually their heart.
That is the nightmare scenario, and it happens. That's why the index of suspicion has to be so high. You see those symptoms in one of those groups, you have to be thinking ACS. You rule out the heart first.
Okay, so we suspect ACS. Now we have to figure out which kind of ACS it is because the treatments are so different. We've got the big three, STEMI, NSTEMI, and unstable angina. How do we tell them apart?
We use two main tools. We use the ECG, the electrical trace of the heart, and we use blood tests for biomarkers.
And the key biomarker is troponin.
Troponin is the one. It's a protein that leaks out of heart muscle cells when they die.
Yeah.
So if you find it in the blood, it means damage has already been done.
So let's break it down. The most urgent one is STEMI.
By far.
Right.
ST elevation myocardial infarction. The ECG is the key here. The ST segment, which is usually a flat line, is physically elevated. It looks, they call it a tombstone for a reason.
Not a reassuring name.
Not at all. And that elevation, plus a high troponin level, tells you one thing. A coronary artery is 100% blocked. Right now.
Okay, so that's STEMI, elevation plus damage.
Yeah.
Then NSTEMI, non-ST elevation.
Exactly. In STEMI, the artery isn't totally statically blocked. It's severely narrowed. Maybe a clot is forming and breaking up. So you do not see that ST elevation. But, and this is crucial, the troponin is high. The muscle is still being damaged.
So no elevation, but still damage, which leaves the last one, unstable angina.
The tricky one, the warning shot. With unstable angina, you get no ST elevation.
Right.
And critically, you get no elevated troponins.
So no damage yet.
Not yet. But the patient is unstable. Their chest pain is new or it's happening at rest. They are right on the edge of having a full-blown heart attack. That distinction drives everything.
Before we go down those different paths, we have to talk about what you do in the first 10 minutes for everyone. And this is where things have really, really changed. I remember learning the acronym MONA.
Oh, MONA, yes. Morphine, oxygen, nitrates, aspirin.
It was gospel. But looking at the 2020 guidelines, MONA is, it's pretty much been dismantled.
It's a great example of how medicine evolves. Let's start with oxygen. For decades, it was automatic. Chest pain. Here's an oxygen mask. The logic seems simple, right? Heart needs oxygen, so give it more.
Makes sense to me. So why did we stop?
Because it turns out giving extra oxygen to someone who isn't actually low on oxygen, someone who isn't hypoxic, can be harmful.
Harmful? How?
It causes vasoconstriction. It can actually clamp down on the blood vessels, including the coronary arteries. So you might be reducing blood flow to the heart, the exact opposite of what you want. So now the rule is simple. Only give oxygen if their SATs are below 94%.
Wow. That is a huge reversal. What about morphine, the M in MONA?
Also used with major caution now. The issue is that morphine slows down the gut. And if you've just given someone life-saving oral antiplatelet drugs like aspirin or clopidogrel, you need their gut to absorb them as fast as possible.
So the painkiller actually gets in the way of the treatment.
It can, yeah. So it's reserved for severe pain that isn't touched by other things. It's not a first-line automatic choice anymore.
So what's left of MNA?
Nitrates and aspirin are still standing. Nitrates are great for pain. They help open up the vessels. You just have to be careful if the patient's blood pressure is already low.
And aspirin is the one that's non-negotiable.
Absolutely. 300 milligrams, chewed immediately. That's the one thing that has stood the test of time.
Okay, so we've got the patient, we've given aspirin, we've checked their oxygen levels. Now we look at that ECG. Let's go down the STEMI path first. That's the big emergency. How specific are the criteria for calling a STEMI?
It's defined down to the half millimeter. It's incredibly specific. The changes have to be in at least 2 contiguous leads, 2 leads looking at the same part of the heart.
And I was fascinated to see that the criteria are actually different depending on your age and sex.
Yes, that's a critical point. So let's take the V2 and V3 leads, which look at the front wall of the heart. In a man under 40, you need at least 2.5 millimeters of elevation.
Oh, okay.
But if he's over 40, that drops to 2 millimeters. And for a woman, any age, it's just 1.5 millimeters.
That's a huge difference. A 2 millimeter elevation that's a massive heart attack in a woman could be considered normal in a younger man.
Exactly. If you use the male criteria on a female patient, you will miss her heart attack. It's that precise. And then for most of the other leads, it's a flat 1 millimeter cutoff.
And there's a wild card, right? Something called a new left bundle branch block.
The wild card, yeah, LBB. It's an electrical conduction problem that messes up the ECG so badly you can't see the ST segments. So if a patient has chest pain and a new LBBB, you can't wait. You have to assume it's a STEMI and act.
So we've called it. It's a STEMI. Time is muscle. The clock is ticking. What's the goal?
Reperfusion. We have to open that blocked artery. And we have 2 ways to do it. Mechanically, with PCI balloons and stents, or chemically, with fibrinolysis clot-busting drugs.
And PCI is the best option.
It's the gold standard, yeah. Better outcomes, less risk. But you can only do it if you have a cath lab.
Which leads to the 120-minute rule. This is purely about logistics, isn't it?
It's all about logistics. The rule is this. Can you get the patient to a cath lab and have that artery open within 120 minutes of the time you could have given them the clot-busting drug?
Okay, so walk me through it. I'm in a small hospital, no cath lab. Patient comes in. My options are give the drug right now or ship them to the big city.
Exactly. And you look at your watch. If the big city is 3 hours away in an ambulance, that's 180 minutes. You've blown past the 120-minute window. You have to give the drug right there, right now.
But if the big center is only 45 minutes down the road,
then you don't give the drug. You get them in the ambulance and you go for the PCI. Because you can get the superior treatment within the time frame. It's a high-stakes calculation.
And if you do give the drug, you're not done. You have to check if it worked.
That's right. You repeat the ECG 60 to 90 minutes later. If the ST elevation has come down by at least half, great, it worked. If not, that's failed reperfusion. The clot is still there.
And then
they need rescue PCI. At that point, all bets are off, and you send them to the cath lab no matter how long it takes.
Let's talk about the other drugs for STEMI. We've got aspirin on board. What else?
You need a second antiplatelet drug, DAP, dual antiplatelet therapy. The choice here depends on one big question. Is the patient already on a blood thinner?
For something like atrial fibrillation.
Exactly. So if they are not on a blood thinner, the go-to drug is prasugrel. It's very potent.
And if they are on a blood thinner?
Then prasugrel is too risky. You'd have 3 blood thinners working at once. The bleeding risk is huge. So in that case, you step down to clopidogrel. It's a bit milder, a bit safer in that combination.
Okay, that makes sense. So that's the STEMI pathway. It's very algorithmic. Now let's switch gears to NSTEMI and unstable angina. This feels murkier. The ECG isn't shouting at you.
It really isn't. And that's why the whole strategy changes. For STEMI, the strategy is speed. For NSTEMI, the strategy is stratification. Risks stratification.
We're not treating everyone the same way.
Not at all. We have to pause and ask, how high risk is this particular patient? We need to calculate their odds.
And for that, there's a tool, the GRACE score.
GRACE score, yep. It pulls in a bunch of data points: age, heart rate, blood pressure, kidney function, whether they got cardiac arrest or ECG, their troponin levels.
And it spits out a risk percentage. What do we do with that number?
We basically split patients into two groups. There's the low-risk group, which is a 6-month mortality risk of less than 3%. And then there's the intermediate to high-risk group, which is anyone over 3%.
And that 3% line is what determines the timing of their angiogram.
It's the key decider. But first, a quick caveat. If the patient is clinically unstable, their blood pressure is crashing, they're in heart failure, we ignore the score. They go to the cath lab immediately.
Right. You treat the patient, not the number?
Always. But for a stable patient, if their GRACE score is over 3%, they should have an angiogram within 72 hours.
And if it's under 3%?
Then we have time. We can manage them with medication, maybe do a stress test later on. We don't necessarily have to be so invasive right away.
Let's touch on the medications for NSTEMI. We used heparin for STEMI. Is it the same here?
Actually, no. The preferred drug for NSTEMI is different. It's called fondaparinux.
And why the switch?
It's safer. The big trials showed it works just as well as heparin, but causes significantly less major bleeding. So, better safety profile.
But there's a catch, isn't there?
A huge catch. It's cleared by the kidneys. So if your patient has poor kidney function, specifically a creatinine over 265, you can't use it. It'll build up.
So in that case, you go back to heparin.
You switch back to good old unfractionated heparin. Or if you decide the patient needs an angiogram immediately, you'd also just stick with heparin because it's easier to manage during the procedure.
So fondaparinux is the default, unless the kidneys are bad or you're rushing to the lab.
That's the rule of thumb. And it's those little details that really matter.
We have covered so much ground here, from figuring out if it's even a heart attack, to busting the MONA myth, to measuring millimeters on an ECG and calculating risk scores.
It's a lot, but it all fits together. It tells a story about how modern cardiology works.
It really does. It feels like the biggest theme is moving away from a one-size-fits-all approach.
That's the perfect way to put it. 50 years ago, the treatment for a heart attack was morphine, oxygen, and bed rest. We just hoped for the best.
And now?
Now, we're measuring ST segments to the half millimeter. We're adjusting our diagnostic criteria for a patient's sex and age. We're using massive global databases to calculate a person's 6-month mortality risk down to a decimal point. And that number decides if they go to the cath lab today or in 3 days.
It's a shift from general care to precision algorithms.
Exactly. We're not just treating a heart attack anymore. We're treating a very specific physiological and electrical event in a very specific individual.
And that precision is what saves lives.
That's the whole point. That's why we have these guidelines. It's about getting the right treatment to the right person at the right time.
A powerful place to end it. Thank you so much for breaking all of this down for us.
My pleasure. It was great to get into the details.
And thank you all for joining us on this deep dive into acute coronary syndrome. We'll see you next time.
If you like this series, please hit the like button and subscribe for videos like this. Bye for now.